in diversified investment financing model for healthcare, that private practice is the viable model which you have established, are there conditions that need to be made first for it to be sustainable?
Yeah, I think the number one thing is the mindset, consistency. If set up your life in a way where it doesn't take willpower. I'm prone to action, and that is the best teacher. Real life experience is the best teacher. I can read in a book, and I did read books. I can read a book all day, what we need to do, how we need to do it. But until you get out and actually do that, you're not going to really know what succeeds and what doesn't.
Hello and welcome. You are listening to the podcast that asks the question too many people forget. What about rural health? I am your host, Chinasa Imo, and together we are uncovering the stories, the challenges, and the innovation that is shaping healthcare in overlooked communities. Today's episode brings us to focus on a conversation that asks how to improve rural health funding mechanisms and investment diversification so that access goes beyond basic care to include specialized and sophisticated services that rural communities also need. In the United States, nearly 60 million people live in rural and semi-rural communities, yet fewer than 10% of physicians practice there. At the same time, more than half of the rural hospitals are operating at a loss, and access to specialized care is becoming harder every year. When we talk about rural health funding, the conversation often focuses on government budgets, donor funding, or health insurance. But the reality is that public funding alone is no longer enough to meet the needs of rural communities. As budgets get tightened, many healthcare providers are quietly being pushed out of practice, not because they no longer want to provide care or because patients do not want care anymore, but because the business of delivering this care is becoming unsustainable. So the question becomes, if public funding alone cannot carry the weight of healthcare, what other model can we introduce or can we look at as a way to keep local people accessible to healthcare in ways that are sustainable? And what does that mean for rural communities who simply cannot afford to lose another provider? My guests and I are going to explore, all of this model, or at least one of this model that is called private practice. Not as a profit-first medicine, but as a viable financing and care delivery model. When done right, this can expand access to timely and specialized care, support providers who provide services in places where big hospitals are unable to cover, and ultimately improve patient outcome. But before we dive into this, let's take a quick break.
If you're enjoying this conversation, don't forget to subscribe to What About Rural Health on all podcast streaming platforms. We are on Spotify, Amazon Music, Apple Podcasts, Listen Now, and so on. And yes, we are on YouTube too. Your support means a lot to us. Please leave a comment, share, and most importantly, give us a review. It helps others discover this important conversation.
All right. Welcome back. You are still listening to What About Rural Health with Chinasa Imo. And without much ado, let me introduce you to my guest. Joining me today is Dr. Rishin Shah, a board-certified cardiologist and vascular specialist with over 15 years of experience caring for patients across diverse communities. He is the founder of Prime Heart and Vascular, where he serves patients in Plano, Frisco, and Allen, Texas, through both in-person and telehealth care services. He has a strong focus on prevention, patients' education, and minimally invasive treatment. What makes Shah's work especially relevant for our today's conversation is that he's not only a clinician, but he's also building a system that is working, and he will tell us a lot about that. He chooses to navigate the realities of the rising cost of healthcare and the shrinking government funding and reimbursement model to build a sustained private practice that prioritizes patient-centered care while remaining financially viable. His work challenges how we think about private practice and probably will shift our mind towards seeing the model as a real opportunity for keeping care accessible, specialized, and close to the communities that need it the most. So, Dr. Shah, welcome to What About Rural Health?
Thank you so much. I'm looking forward to having this conversation with you. Thank you for having me.
Thank you so much. I had a conversation with someone earlier this week, and we talking about private practice, and he does physical therapy, but as a private practitioner. And I asked him a question, and this question I'm going to also throw it to you. Why did you move into private practice?
That's a great question, since I'm passionate about it. When I was in my cardiology training, most cardiologists were in private practice, meaning they had their own business, they made their own decisions, they had their autonomy of how they wanted to take care of their patients. And then over the last decade or so, the vast majority of cardiologists have become employed by hospitals. So they're employees of big hospital systems. And that's just because the incentives of how insurance reimbursement works has been changed, where it's more favorable to these people that are employed by hospitals. However, I wanted to be closer to the patients. I did not want to have administrators that had never seen a patient, taking care of a patient, telling us what to do. And I heard stories of multiple mid-career cardiothoracic surgeons, cardiologists, that despite taking good patient care, were shown the door for other, non-clinical reasons. So all that kind of pointed me to private practice in the first place. My initial job was not my own private practice; it was a big private practice group. But that's the reason I personally stayed away from hospital employment in those initial days.
Thank you so much for that response. And I know that we'll come back to this conversation, but I want to zoom out a little bit and talk about it from a systems perspective. As a practitioner, from where you sit, what do you see that is the most fragile thing within the healthcare system, that is in the way care is currently delivered in the US, especially outside of a well-resourced environment?
I mean, I don't think it's debatable really to say that healthcare costs are out of control, right? And that is by far the biggest issue. And with the subsidies of the marketplace plan, exchange plan going away, I have tons of patients that their premiums are going up by 40%. And we all know that American healthcare costs are the highest in the world. Partially that's because we have such great technology and we're able to take care of all these patients that have really bad diseases. Most of the innovation comes from the US in terms of R&D and drug development. And when that happens, we do bear most of the costs. So there's some part of that capitalistic part that makes costs very high here. But also the incentives are set up. I spoke about cardiologists being employed by hospitals. Hospitals get these things called facility fees, which increases their reimbursement by all insurance payers. So if you come to see me and I do a test, an echocardiogram, which is an ultrasound of your heart, so I can look at the structure and function, I might get paid $200, $250, depending on insurance. The hospitals get 2 to 3x, to do the exact same test. And so because of these incentives, they've been buying up doctors' practices. And then that just causes costs to go even higher. But if we're even going to talk more from a clinic and patient example, like we need to focus a lot more on prevention. We need to focus a lot more on patient education. We need to have, instead of a sick, take care of sick system, more of a health system. So I think there's lots of opportunities there, and happy to talk about any one of those you want.
So thank you for that response. And I do have a follow-up question to ask you. From your bio, it's obvious that you've been in this game a long time, at least 10 to 15 years. So if we're going down the memory lane, what is it that you saw within the traditional health system in the way that it is that you looked at and you were like, nah, this not gonna be for me. I'd rather just, as a physician, stay within the private practice that I started off with and branch off for my own, on my own, and set up a practice where I can actually work directly with the patients and not be interacting through the traditional systems with all of the administrative and funding process.
I think the number one reason physicians branch out on their own is autonomy. We want to be able to make clinical decisions on our own. We want to do what's best for the patient that's sitting right in front of us, right? We're talking to patients one-on-one, and we want to make the best decisions. But also, when you're stuck in a big system, because you're kind of away from all the front desk activity, you don't really know what you're missing from a non-clinical standpoint, meaning, and I'll give you an example from my wife from yesterday. She was calling a lung doctor's office. She was on hold for 45 minutes to talk to someone. 45 minutes. Now, if you're, a patient that's uncomfortable in pain, you're trying to navigate the medical system. This is one of 5 specialists you have to see. Like, how would you as a patient feel if you have to wait 45 minutes on hold just to talk to someone, get some information? I went on this website. There's no patient portal. There's no email address. There's no other way to communicate. And so I saw that as well. And that frustrated me as, a person trying to take care of these patients. And that's just one example where now, because we're in our practice, we've set up very clear KPIs that I want literally 0 missed phone calls. All phone calls need to be answered within 1 minute. And if they're not, I hire more people. Or we use technology or whatever we need to do. But because I see that front end, I'm able to be involved. And this is the type of things that I think doctors can do. Yes, do we want to make money and all that kind of stuff? Of course. But I went into this field first and foremost to help patients, take care of patients. That's what brings the greatest joy when someone says, Dr. Shah, you made a big difference in my life, right? To get a hug or something like that. And so I want to take care of these patients. So it's just, you're closer to the front lines and you can make changes in these sorts of things. So I think by far autonomy was the number one.
I like that. And I know I have a conversation that I'm going to bring back the conversation about autonomy to you. But looking at you starting off from a collective of practice to branching off and starting your own establishment, this is a personal question you ask that I ask every person that's a social entrepreneur. Did you experience fear stepping out of your own? What were that risk what is the biggest risk that was weighing you down when you started, thinking, oh, can I do this? Can I succeed? Things like that.
Yeah, I think the number one thing is the mindset, right? That you can frame things as fear or you can frame things as opportunities.
That's true.
I really saw it more as an opportunity. I can do things what I think is better. Fortunately, I'm in a profession where I will always be needed. So that actually made things easier to get started. And part of it is also I'm a shoot then aim type of guy. I'm prone to action, and that is the best teacher. Real life experience is the best teacher. I can read in a book, and I did read books. I can read a book all day, what we need to do, how we need to do it. But until you get out and actually do that, you're not going to really know what succeeds and what doesn't. And, we don't get any experience in doing this kind of stuff in med school. There's zero teaching about how to start your own practice, on how to manage all the insurances, right? Our education, as it should be, is 100% on how to be a good doctor. So I wasn't truly fearful. Fortunately, I had been employed for a couple of years, so I did have some some money in my bank account to make it through. But I will tell you, I've never worked harder in my life. Right? When your decisions and your effort, like you have to do things to put food on the table. Like I've never worked harder in your life, and you have that pride and joy of this is my thing. But yeah, fear, fortunately for me, wasn't one of them. And I got to also give props to my wife. She had actually started her own practice a couple years before this. And so I saw what was possible, right? So if you see that possibility, right, that opens your mind. And so that also helped.
Thank you so much. And I'm glad that you mentioned that you had help, including from your wife, just learning through the hoods of people who have started the journey before you. But my other next follow-up question is, at the point that you were starting, and I know a lot of things would be part of why someone would branch off to start off anything, including myself running podcasts. But what was the most important thing about the mission that you wanted to accomplish?
Yeah, I mean, it's taking good care of patients. I mean, that's, when your mission as a physician is to take care of patients, 99% of other things will work out. Yes, you're right, you need some education, you need to learn, but as long as your North Star is do what's best for the patient, I think you can really figure out the rest of the business, insurance, things like that. So that was the mission. It is the mission. That is the mission. That is why I'm passionate about helping other private practice doctors as well, because we all have, the vast majority of us have the same vision and passion, right? So I wanted to make this model successful for the next 100 years.
That is good. So I'm going to come back to the concept of private practice, because the truth is, including myself, when we hear about private practice or when someone introduces themselves as private practitioner, what jumped through our mind is, oh, that guy must be a costly person to access care, in their facility, or, oh, they serve a certain class of people who can afford it, or their services are exclusive, or they are profit driven. And there are different things, different perspectives that we think about when we hear the word private practice. And these things provide certain level of misconception to how people prepare whether to go to a public hospital, a group hospital, just go to a private practitioner. Can you help us unpack all of these things, or at least explain in a way that help us understand better what private practitioners do and how they position themselves?
Sure. So there's different models of care. So if we're talking about traditional insurance model, you can either be seen by a private practice that is basically they are running their own business, or you can be seen by a group that is employed by a big hospital system. Typically, from a cost perspective, the private practice will actually be cheaper because the hospital groups, as I mentioned in the beginning, charge these things called facility fees. So for the exact same, service, seeing the doctor, getting a test done, you'll pay significantly more when they are employed by the hospital or when it's a hospital-owned practice. And that is why lots of hospitals have bought up practices. So private practice doesn't mean we're exclusive in a traditional insurance model. It does come down to what insurances they take, right? So many primary care doctors in the Dallas area where I am don't take Medicare. Medicare is insurance for those above 65 because it doesn't reimburse as much as commercial insurances. So there are some practices that make those sorts of decisions. I take Medicare because I'm a cardiologist, and if I didn't, I can't take care of the most vulnerable people because in my practice, it's mostly the elderly. There are other models of care. One is called direct primary care, which is basically pay a monthly subscription fee to the primary care office. Usually it's about $150 a month, and you get to see that doctor unlimited times in those 30 days. And so that is a very affordable way for people that may not have insurance or may have only catastrophic insurance to get affordable care. And then on the other spectrum, there's something called concierge medicine, right? Concierge medicine is they take your insurance, but then you also pay an additional fee on top of that, so you have more access to your physician. Typically, for this model, they'll have much smaller panels, so you get much more personalized care. So that, yes, that would probably be more for that, right? People that want to spend that money for that extra care. Insurance-based model is what most people know and understand. And then there's the direct primary care model, which is a monthly subscription fee. So now they've come out with these different models. So depending on what kind of needs you have, you could potentially fit in one of these models.
Thank you for providing this clarification. I did not know, because to me, when I hear private practitioner, I just think about, they are very exclusive and they are very costly. So I'm glad that you provided this explanation for us to know at least there are different categories of care delivery model, depending on whether it's large system or private practice. I'm trying to get this sink into my head. But one thing I heard you, and that's the impression that I had prior to us starting this podcast, is that private practitioners enjoy autonomy and independence because there's no, intermediary systems that is running show for them. They are literally doing this themselves, and sometimes in a small scale, some in a large scale. Like if I would pin my mind to the explanation you gave earlier about working in the midst of a chain of private practitioners versus you working on your own, all of these things, I look at them and I say, they want to be autonomous and independent. Help me if this is not entirely true, and feel free to push back where you think I get it wrong. But in essence, what I'm trying to ask is, what does it require to run a private practice financially and operationally?
No, I think you're right. Autonomy and independence is a big deal. I didn't get my first real job till age 35, right? So I had 30 years of education to do what I do. And so we're super specialized. So we want to, again, make those decisions and make good clinical decisions on our own without having to worry about what administrator bureaucracy, what the bureaucracy is saying. We want to really practice at the top of our degree, the top of our license. I do agree with that assertion. Now, what does it take to run a private practice in 2025? It gets harder every year, frankly, because especially since pandemic, inflation, right? The costs of everything has gone up. Wages have gone up. Supplies have gone up. I think every single vendor I use has increased prices multiple times since 2020. And I think what most people don't realize is I don't control what I make. Meaning the insurance company controls what I make, right? So they decide how much you will pay and how you will pay, right? So many times we are the face of the business, right? So patients get upset at us about billing issues. And really it's us, we're just following insurance rules. We have contracts with the insurance company, so we have to follow their rules. But that amount keeps going down. So the margins keep going lower and lower. So during this process, I've had to find some innovative ways to stay in business, stay viable, and also make sure my patients are being taken care of. One of the big metrics I talked about was I don't want anyone waiting for more than a minute on hold. Mm-hmm. One of the big things I've done is I use offshore staffing in my practice, and we've developed a business and we help other physicians do that as well. It's called Goline Health, but we employ people from all around the world, and they have great communication skills. They can answer phone calls. I have nurses that can from the Philippines that are actually licensed in the state of Texas that can answer all the medications questions. So that's helped with that staffing costs. And also, I use automation with software. So instead of looking at my computer and just typing, right, well, I can focus on the patient. I'm not asking all the same questions that all the questions that are just kind of the admin type stuff, but I can really focus on listening to you, hopefully making you feel heard and coming with a game plan on how we can take care of you. And then it's developing systems, right? I never knew what a standard operating procedure was until I started my practice. And so having systems in place where you can really make sure you're getting these things done on a repetitive manner, and you're not having to always have this worry in the back of the mind, is this getting taken care of? So I think delegation, automation, systemization, all those have really, really helped us succeed.
Thank you for that response. And I wanted to ask you, based on all of this, what was the particular problem you were trying to solve when you built Prime Heart and Vascular? Do you have a rural health story that needs to be heard? Whether you are a health worker, a patient, a policymaker, or an advocate, we want to hear from you. Share your stories on our website at www.whataboutruralhealth.com/stories and help us amplify the realities behind the data. Someone from our team will contact you with details on how to get your story published on our newsletters, websites, and other media platforms.
So I think it was seeing my patients not getting responded to, not getting what I thought was adequate treatment in terms of communication. I think that the biggest complaints I hear are when I basically put it down to communication, right? Whether it comes down to, for example, billing, a lot of patients don't understand all the nuances of insurance. I barely understood it until a few years ago, okay? There's these terms like deductible, co-insurance, co-pays. What does that all mean? Right? Patients think that, I have insurance, so it's covered. It's covered, but I don't know what your out-of-pocket is, because that's all based on all of these different terminologies and things like that. So making sure we do a really good job communicating that. If you're nervous and you're scared and you're calling in, I don't want you waiting on hold for 45 minutes. I want us to communicate what's going on. Or, hey, and I even had this coaching session with one of my, we have a weekly staff meeting with one of my staff members this last week. Like, it's a newer staff member, and they were afraid of saying, I don't know to something, right? If a patient calls and you don't know, say, I don't know, and say, but I will get the answer for you and I'll get back to you within 24 hours or whatever that metric is. And they're going to be way more appreciative. Hey, you didn't know, but you went the extra step and you went above and beyond, right? That's a big thing that I look for people that we hire, is your willingness to go above and beyond and just take care of our patients. And you got back to them. They're going to be even way more appreciative. So, I think those are the main things I really wanted to improve, and being able to practice at the top of my license, right? I want to just focus on the patient and take care of you the best I can.
Thank you. I wanted to ask, you have these different centers around clinics around Texas. Do you see any kind of weighted difference between the patients you serve in Plano, I think I got it right, versus the one you serve in other places? Is there like behavioral difference, things that show up that make you have probably a different kind of system that serve these different clinics or population group?
I mean, it's a couple of the clinics, I do get patients from hour, 2 hours away sometimes. So speaking about rural health, right, there's not really cardiologists in those areas. One of the best things that come out from the pandemic is the wide availability of telemedicine, right? So like that, I think, has been a game changer for a lot of these patients. For the first visit, for me, I have to do something called EKGs. We might have to do some testing of the heart. So for those, they'd have to travel to come to the office. But after that, the regular follow-ups we can do by televisits, right? So that's been a big game changer. There's also something called remote patient monitoring, where they can have blood pressure cuff or scale or whatever kind of device, and we can get physiologic data sent to us remotely. And so we can keep track with them objectively. We can see them from their home. And so obviously it helps a lot if they're not needing to travel 2 hours away. So that access to care issue is real, and I do see it in my own practice. But fortunately, with some of these technologies that have come out, there's lower barriers to care.
Thank you. And I want us to stay a little bit more on this access to care and technology, because Literally, 70% of my guests have either muted it or offered it or recommended it as the best route to go. But I still do have a lot of critics about what that means when we put into context that not all communities do have access to technology. And then not all population do understand, even when these technologies are available, do understand how to effectively use this. So, how do you navigate that? Say, a grandpa of about 85 years who's, you know, he's joined technology in his later part of his life, and now he has to assess care in some way through technology because we are also trying to reduce the pressure of him being driven up and about just to go to the clinic, which solve a lot of issues, other issues for him. But now he has to grapple with, how do I navigate this technology to get to my doctor? What do you do with is in situations like that?
Yeah, that is not easy. Sometimes there's family members, which obviously helps. I'll give you a simple example from our own clinic. So one of the things we do is because I'm really big on prevention and lifestyle changes, we have dietitians and personal trainers that they can talk to and virtually, through televisits, and it's completely free for them through their insurance. And so I've been really passionate about trying to recommend that. But we had an app where they had to sign up for and do all this kind of stuff, and not just my elderly patients, right? Just some of my quote unquote normal patients wouldn't sign up for the app. Is that one extra step they would not do or is more difficult to do? So we just changed the process up where we just text them a link. I think most people are at least comfortable with text. They can text their grandkids. They're using that for some part, even if they may not use the apps or may not use the other functions of the phone. I think most of them are comfortable with text. So now they just have to click, they get a text link 5 minutes before their appointment. All they do is click on it and they show up and then they hang up. So that one little, many people can consider a minor change, increased our rate of acceptance of these visits significantly. So there are, people that don't care about technology, people that don't want to spend time with technology. I'm in my mid 40s and I don't know all the new technology now, right? All the like I've kind of gotten away from that now, so I can definitely empathize with those in their 70s and 80s. But we try to also educate. We spend time here. When we had the app, we would have our front desk try to spend time to educate on how to do all this stuff. But yeah, there's still that barrier. So we try to simplify it as best as we can.
Thank you for that response. In some way, I was hoping that you would get us to the technology part, because at the barest minimum, everyone right now knows how to click on something
Right.
or press on something and move on. And if technology could be made to be this user friendly, I think it will solve a lot of problems. I know we have issues about coverage that is beyond medicine. That's a whole different infrastructural problem. But at least where these technologies are already available, how do we make them user friendly? And you've just taken us through that. I think it's worth for us to pause here for our listeners. And in doing that, I want to emphasize that just what you said, that private practice essentially are mostly small businesses, balancing staff, equipment, rent, insurance, patient care. In rural communities where most of this private practice is very key to how people go to health facilities or receive services, I see and I hear you thinking about, discussing a lot about how you think about adaptation to changes within the health system landscape. And there are also some risks that are part of it, but you navigate all of these things because you also in some way understand the community dynamics, right?
Right, exactly. You got to understand that a little bit too.
Thank you so much. So, to our listener, as you listen to this conversation, I want you to pause and reflect and connect this to your own community. And feel free to leave us a comment or your opinion in the comment section. In your community, What healthcare services do you find difficult to access? And how much of that do you think is tied to how care is funded rather than how much it is needed? And if private or community-based practices were better supported where you live, how might that change when, where, and how you and your loved ones seek care? Thank you so much, Dr. Shah, for joining us and for sharing not just your expertise as a clinician, but your vision for making underserved healthcare accessible and sustainable. For our listeners, I hope this inspires you to think differently about rural healthcare funding and the role private practice play or can play in keeping care local and accessible. To everyone listening, thank you for joining us on today's episode of What About Rural Health? If today's episode moved you, challenged you, or make you think a little bit differently, please follow, subscribe, leave us a review on your favorite podcast platform. And as always, we will keep asking the question, what about rural health? Until next time, I'm still your host, Chinasa Imo. Bye for now.